Welcome to MedEvidence, where we help you navigate the truth behind medical research with unbiased, evidence-proven facts, powered by ENCORE Research Group and hosted by cardiologist and top medical researcher, Dr. Michael Koren.
Hello, I'm Dr. Michael Koren. I'm the host of MedEvidence. I'm a cardiologist, and I have the distinct pleasure of having Dr. Alpa Patel join me for a series of discussions about palliative care and hospice. And she shared with us really just some very moving information about her dad, who went through a very long course of being treated for oral cancer. Was trying to decide between a curative approach and a, quote, palliative surgical approach. Eventually did some palliative surgery, did some radiation that was palliative, and had a lot of ups and downs, but is still with us and is actually doing well in a palliative care environment. And Dr. Patel and I are also clinical trial people. And what I want to do in our final session in this series is talk a little bit more definitionally and help people understand what the difference is between hospice and palliative care, and maybe how we can study it and how it has been studied in the past, and the challenges of studying it in a critical way, the way we study other areas of medicine. So with that, do you want to just give a quick description of, quote, palliative care versus hospice?
Yeah, so palliative care is longer-term care to provide comfort for chronic medical conditions, patients that have certain diagnoses such as even Alzheimer's, congestive heart failure, COPD, any severe chronic medical condition, they can be enrolled in palliative care. Even cancer patients who maybe have slow-growing indolent cancers that they don't undergo curative treatment for can also be in palliative care. However, once you decide to stop any type of treatments for that cancer or underlying diagnosis, then you can enroll in full-term hospice if you have 6 months or less to live. And I mean, some of that's subjective. I mean, no one can really gauge that, and you can definitely be recertified in that process after the 6 months.
So just to reinforce that for people who are listening in now, so full hospice care as a Medicare or insurance company approved benefit is typically for people who are certified to have less than 6 months to live. And I think we should also point out that hospice and palliative care does a lot of good and there's a lot of caring involved, but it's not completely a eleemosynary exercise. And I use that word because I like to throw in SAT words every once in a while, but eleemosynary or eleemosynary is charitable.
Yes.
And people actually get paid for this, to be clear.
Absolutely.
And so people are part of organizations that provide these services, and these are either nursing homes or home health services, et cetera, that get reimbursed by insurance companies for the services they provide to people who fall into these conditions. So the definition for Medicare purposes, again, is having a limited prognosis. But for palliative care, there's much broader inclusion.
Yes. Yeah, I've had patients in palliative care be in there for over 5 years, and they're still in palliative care, but it gives them and the family additional resources where they're able to get equipment, things set up in their homes, CNAs. The medications are then provided by hospice, and it makes it a lot easier for the patients and families to take care of the sick patient. But the palliative process, I used to think also was something short-term, maybe a year or two, but I mean, it can be as long as it needs to be.
Right. So again, we're clinical trialists, and the questions that we ask are, does it work? And how do you know it works? And typically, when we do clinical trials, we use a certain procedural concepts that are tried and true. And one of them is the concept of randomization, which means that you decide by chance if somebody's going to be getting treatment A or treatment B, or diagnostic test A or B, or something that you're testing that's new versus the control or the old way of doing things. And that's picked by random. That's why I call it randomization. So that's one concept. Then we have the concept of blinding, and that's to prevent biases. So if you believe in treatment A, Well, it's only natural that if you know the patient's on treatment A, you may look at that patient differently than if you didn't know what that patient was on. So we like to be objective in clinical research and blind people. Okay? So these are two very important things, but are they possible when we look at palliative care? If we want to know if a aggressive approach and just doing things the way we always do it versus a palliative care approach is going to make a difference, can we utilize these tried and true measures of clinical trialists? Any thoughts?
I don't see why we can't measure it. I mean, in those patients that undergo palliative care, at some point, I feel like they have been offered aggressive treatments, and maybe either they were not candidates for them medically or the patient opted not to have them. It would be interesting to see how that cohort of patients does versus the ones that decide to just get comfort. Do they live longer? What type of quality of life do they have? What are our outcomes with the types of aggressive treatments that we suggest to patients?
So and those are great points. To get back to the point of randomization, what people don't always realize is that you can randomize by patient, which would be very difficult in a palliative care study. So if you said, okay, we want you to sign up for a trial, we may put you into palliative care, or we may, treat you as aggressively as we possibly can. So I'm not sure that would work for an individual patient because obviously they would want to have a little bit of control over that situation. Right. But what we could do is randomize by site. So, for example, we can have a place that treats cancer patients or congestive heart failure patients and have palliative care as an option that's presented to every single patient. And that is the first option that's presented to the patient. Doesn't mean that patients necessarily have to do that, but in that one site, that's given as the primary option. Whereas another site, by random, just goes about their business in the usual way. They don't offer palliative care as their first option. Now, obviously, if a patient asks for it, you would, of course, let them know that it's available. But the intervention would be in one place where telling everybody right up front that this is an option, the other place it isn't. And then we can compare the experience between the places where it's the first option versus where it's not a focal point. So that would be a randomized study. And then as far as blinding is concerned, the IRB would have to approve that institutional review board, but the physicians would be not easily blindable under those circumstances, but the patients could be. Right. So the truth is that there are practices out there that have more or less of a focus on palliative care. So the patients don't even necessarily need to know under these circumstances that this is being studied at the site level because their experience is with the different practices. So you have to be able to use a practice that is equally comfortable with their primary focus being palliative for certain congestive heart failure patients versus the aggressive approach that has been the standard for many years. So there are ways around these things is my point. And then to your point about outcomes measures, you have to, again, give the patient the opportunity, just like your dad had the opportunity, to define what their measure is. Because what we've learned is that an outcome measure that is part of a typical research study is going to be somewhat focused on what the regulatory authorities think is important and what doctors think is important, but not always what the patient thinks is important. Right. And in something like this, what the patient thinks is important is really arguably the most important thing. So perhaps we could set up a study where the patient defines their outcome measure, and what you ask them, what is the most important thing to you? And then that becomes what we try to achieve. Right. Now, of course, the length of life is something that's easily measurable, and that should certainly be something that we look at, and that'd be important. There are surveys that can be done to talk about the quality of life, and some of these have been validated surveys, so we can certainly look at those things. But perhaps the thing that would change this dynamic is that you have a primary endpoint that's patient-derived. Now, not all patients are articulate enough to say that, so we'd have to give them some choices, of course. Sure. But they can decide. You can say, okay, what's most important to you? Living as long as possible, eating as many meals as possible, taking a walk every day. You decide, and we're going to see if this system gets you to your goal more or less, depending on what we randomize you to.
Mm-hmm.
So anyhow, just some thoughts in terms of how you might want to
interesting.
structure that type of trial.
Yeah, I think it would definitely be interesting, and it'd be interesting to see if which companies can achieve this better versus others, because patients have choices in the companies they use for palliative care or hospice. It's a covered benefit under most insurance companies, but it's administered by different groups.
Right.
And it would be an interesting study to see if one group does this better than others.
Exactly.
You know?
So the other thing, of course, is cost. I used the word eleemosynary before, and the government is not exactly eleemosynary either. So the reason they pay for this isn't because they're kind and benevolent, it's because they're trying to save money, let's face it. So their concept would be, okay, if we give people the option of, quote, comfort care, maybe they don't do expensive surgeries. Maybe they don't purchase expensive chemotherapeutic agents, et cetera. So that's a fair game, though. I think it's using cost as an outcome measure would be actually important.
Yeah.
And we may be surprised. We may be looking at a situation where you have a palliative approach that not only achieves the patient goal more frequently, but also reduces costs.
Mm-hmm. Yeah, it reduces, I think, recurrent hospital admissions, ER visits,
Exactly.
medication overutilization, all of that.
Yeah, and I think those would be important endpoints to look at, and looking to see whether or not an approach and the fact that we have a whole system in place and resources in place for patients, where they know that we're looking at comfort outcomes, not just longevity outcomes, could make a huge difference.
Yeah, definitely.
Yeah. So we're close to the end of our time, and so maybe you can just summarize some of the things that you've learned through this journey, and I'll give you the last word, but maybe cut in on a couple of quick thoughts that I have.
Okay. So I think what I've learned is patients always have a choice. They have a say-so in how to take care of their health and what their wants and needs are. And I think I've learned from this whole thing that the palliative options or comfort care options are not only just important to the patient, but even to the family and what they can withstand. I mean, watching the struggle my dad went through was very difficult to see somebody just literally not even be able to drink anything. It affected the whole family. And I think now having some of the support in what we've decided to do as far as just comfort and not doing all these aggressive treatments has kind of helped all of us feel more calm and at ease. And I think families have to realize when it comes to that point that you're not really giving up on your loved one. You're just really trying to make sure that they don't suffer more.
Right. Yeah, and what I learned from our conversation is this great idea that patients do have the capacity to define their own goals. And it shouldn't be a unique concept in clinical research, but it is. Because we're always defining the goals for the patients.
Yes.
And the discussion about palliative care and hospice is a great opportunity to have physicians help patients define their goals.
Absolutely.
And then once we do that, then we're very clever at creating research mechanisms and protocols on how to see whether or not we can, in fact, help them achieve what they're trying to achieve.
Sure. And I think, being that I was in the medical field and I was able to make some changes in the way they were administering treatments or protocols made a big difference for my family. But I feel like patients need to be their own advocates in that too. We always see the patients who've done their Google searches and we're looking at that, and balking at it. But I think an informed patient is great to have.
Absolutely. Yeah, absolutely. Of course, Google, Dr. Google, as they like to call the situation, is a double-edged sword, and people can go down the wrong road.
True.
And in fact, that's one
I think
of the
that's where we have to guide them then.
Yeah, that's one of the goals for MedEvidence is to help people understand things because how many patients
But I think that helps maybe asking the right questions.
Absolutely. Well, asking the right questions is extremely important. And then realizing is that on the internet, there's a lot of content that's sponsored, and people are
Yes.
trying to move you in a certain direction because of their proprietary interest. But here at MedEvidence, we're interested in being objective. We're interested in finding the truth behind the data. And I think our conversation has taken us a long way to understand that in the palliative care space.
Yes.
And I truly appreciate your time. I really appreciate the fact that you shared these personal
Thank you.
insights. And I'm so happy to hear that your dad is doing well.
Thanks.
And that your entire patient population is going to benefit from your experience.
Thanks.
Because I, too, have had some family issues that involve taking care of loved ones. And I think it's helped me tremendously in terms of being a
Yes.
better clinician. I'm sure you
Yeah,
could say the same thing.
and until we experience it ourselves, I think we can discuss it with patients all day long, but we truly don't understand what they're going through.
Absolutely.
And
Alpa, thank you so much
you're
for being part of
welcome.
MedEvidence.
Thank you. And I'm sure my dad would love to have you over for dinner now.
That sounds pretty darn good to me.
Thanks for joining the MedEvidence podcast. To learn more, head over to medevidence.info or subscribe to our podcast on your favorite podcast platform.